Hello, and welcome to DeSera Clinical Education's Infectious Diseases podcast. I'm your host, Kimberly Miller. In today's episode, experts Chloe Orkin and Jihad Slim explore the potential clinical implications of new data on optimizing HIV therapy, especially for treatment-experienced people with challenges using currently available regimens, high pill burdens, and reduced adherence. To view the full educational program, please visit the show notes for this episode. Now let's get started.
Thank you so much. So I'm looking really forward to, together with my wonderful colleague, Dr. Slim, talking about optimizing treatment and telling you all about new and exciting things that are just on the horizon. So complex treatments. We know that the gold standard for treatment is a single tablet, and that people living with HIV who are treatment experienced often are not able to attain this level of simplicity due to issues around comorbidities, drug resistance, tolerability issues, and this could mean that they have limited treatment options. And this can lead to pill burden, it can lead to difficulties with adherence, really affecting people's quality of life. And really one of the big concerns is drug-drug interactions because they're at a risk of a higher liability of drug interactions. So there's a real unmet clinical need for drugs with novel mechanisms, new combinations, new agents, and a focus on tolerability and achieving the dream of less is more that we have with so many other people living with HIV. This population has been effectively left behind. We have all these options for simplifying treatment. We can use a 3-drug simple treatment like bictegravir, FTC, and TAF, or a 2-drug simple treatment like dolutegravir 3TC. We even have injectable options for those people who are virally suppressed. And for people who have multi-drug resistance and virological failure, there's the option of optimizing using lenacapavir as an injectable option together with an optimized backbone. And so if we think about what guidelines tell us, guidelines identify that there are certain 2-drug switch regimens which are preferred based on clinical trial data and are more evidence-based. Chief amongst these are dolutegravir 3TC, which is also recommended as an initial regimen for most people, dolutegravir rilpivirine, which is just for people who are switching, and then cabotegravir rilpivirine as a 2-monthly injectable agent, which may improve quality of life and really help people, particularly people who have stigma concerns. But to have these regimens, you need to be virally suppressed, except for dolutegravir 3TC, which you can have as a treatment-naive regimen. But in the case of suppression, you need to be suppressed for at least 3 to 6 months without hepatitis B, no history of prior virological failure, and no evidence of resistance to the drugs in the regimen. So what does BIC-LEN potentially bring to the table? So this is a novel 2-drug regimen with the option to really simplify treatment. And what I'm going to show you is some data from the Artistry-1 study, which was a very, very particular population of people with exactly the type of complex virus that I was telling you about in the background. So to remind you, bictegravir is an INSTI, an integrase inhibitor, and it's oral with a very high barrier to resistance. And then we've got lenacapavir, which is a capsid inhibitor, our first capsid inhibitor, which can be either oral or injectable. And there's no documented de novo resistance before exposure because it's a new class. So here are some phase 3 data. It's very exciting. These data were presented at CROI and they're published in The Lancet. If you're interested in reading more. So Artistry-1 study was looking at switching people from complex treatments. So these people had to have been undertaken for 6 months and having GFRs of greater than 15, so very, very low GFRs were allowed in, no resistance to BIC, no prior treatment with LEN, and no HBV. So it was an open label study where half the participants carried on in their complex regimen and half of them were switched to BIC-LEN. And then they were offered an OLE at the end, open label extension. And the primary endpoint was viral load greater than 50 at week 48 using an FDA snapshot analysis. Now, what do I mean by a complex antiretroviral regimen? So what I mean is a twice-daily regimen, a regimen using more than 2 different agents, a regimen where you also have to use an injection, are some examples of a complex regimen. I'm going to focus now on this population because it is exceptionally novel population. So this is the oldest group of people that has ever been studied in a registrational trial of an HIV agent. The median age for this population was 60 years old, okay, which is really remarkable. 77% were on a PI containing antiretroviral regimen, okay, and most of this was boosted PIs. The most common regimens were PI plus an INSTI in 30%, or a PI INSTI plus an NRTI in 24%. This population also had multiple comorbidities. So 50% had two or more of the comorbidities listed on the slide of dyslipidemia, hypertension, hypoglycemia, or chronic kidney disease. Okay, it's very, very high. And between, almost all of them had at least one comorbidity. And more than half had two additional medications that they were taking as well as their HIV treatment. And you can see there were some people with low GFRs. So in terms of other baseline characteristics, a very, very important figure to pull out is this median duration of prior HIV treatment. This population had been taking HIV treatment for a median of 28 years. Now, we can all visualize these people, who they are. These are the people that took they took pills 3 times a day. They took handfuls of pills. They've really been through it, these people. And in this population, you can see that 40% were still taking twice daily regimens. And there was someone in the study who was taking 11 pills a day. So the reason for the complex regimen, 80% had a history of resistance. So this is important. And in terms of the resistance, you can see that there was resistance across multiple classes. Okay, so we really can get a good picture of who these people are and what their needs are, and that they've been really effectively left behind by drug development so far. So here are the outcomes, the headline findings. Look at the outcome at week 48, Biclen in orange, complex ART in blue. You can see that it was non-inferior to, Biclen was not inferior to maintaining these very complex regimens. There were 3 people in the Biclen arm with a viral load greater than 50, all resuppressed or had low-level viremia with no need to change their regimen. Very importantly, there was no treatment emergent resistance detected in either study arm. So you can see that Biclen was non-inferior to maintaining the complex regimen with no emergent resistance, and the CD4 count remained stable. It was all good in terms of that. Now, if we're going to look at safety and tolerability, whenever you switch a regimen in an open label study, you expect to see more side effects. But in terms of serious side effects, there were no signals in terms of more serious adverse events, grade 3 events at all. There were 5 deaths, none of which were considered to be related to the study drug, and some of them related to cancer or sudden events. Remember, this population had a lot of, were older and had a lot of comorbidities. In terms of the milder sort of more common adverse events, you can see there were very common things like upper respiratory tract infection and headache. But in terms of AEs that led to discontinuation, you can see what the AEs were that led to discontinuation on the slide. And in the complex regimen, there was also a discontinuation due to pulmonary embolism. And actually, in fact, there was a drug interaction in that particular person involving an anticoagulant and a PI. So let's think about other factors. I told you these people had a lot of cardiovascular comorbidities. So what happened to their lipids in the study? So people who were switched away from their PI-containing regimen or their complex regimen to Biclen had an improvement in their lipids. And this is likely driven by taking away the boosted PI, which causes lipid concerns. So you can see significant improvements in their lipids. You can also see, unsurprisingly, very significant improvements in patient-reported treatment satisfaction through the study. There was a big increase in treatment satisfaction as measured by the HIV treatment satisfaction questionnaire with Biclen versus no change with the complex and antiretroviral regimen. In summary, non-inferior with improved lipids, improved treatment satisfaction, and CD4 count remaining the same. So you can see, as I've said, maintaining similar rates of suppression, regimens much simplified, tolerated, And as I've said, improved lipids and no treatment emergent resistance with non-inferior viral control. And with that, I'm going to hand over to my wonderful colleague.
Thank you so much, Chloe. You did a great job. You improved their score by more than double. So hope I could do the same here. Artistry 1 was a very important study for people who needed it badly. So Artistry 2 was more of a study to try to increase the use of Big Clen, increase the more choices of 2-drug regimens that we could switch to for those who needs it, right? So it is a totally different concept. So we're changing gears now. We're talking about a multi-center, double-blinded, active-controlled, randomized phase 3 trials, right? So in this study, they took basically patients who were doing well on, I'm going to call it BF-TAF, right? People who were stable on their BF-TAF regimen for 6 months or more, were undetectable, had a GFR more than 30 milliliter per minute, obviously, because they are on BF-TAF, had no resistance to neither TAF nor bictegravir, and couldn't have chronic hepatitis B either, were randomized 2-to-1 to either switch to Biclen or to stay on BF-TAF. And but because there was a placebo there, so everybody that was on one pill, on a single tablet, one pill once a day, now they have to take 2 pills a day for the next 48 weeks. So it's making it a little bit harder for the patients to participate, yet there was great participation, and you'll see the results in a second. This is 383 patients were switched to Biclen, 191 continued on their BF-TAF, and obviously you have to give the loading dose for lenacapavir in the beginning of the study for the first 2 days. You have to give them, and the primary endpoint was again a 48 weeks primary endpoint for a proportion of people with virus load more than 50 copies per ml at week 48. At the end of 48 weeks, everybody was offered to participate in the open label extension study where they would go on Biclen for, we'll find out for how long. We don't know yet, but at least a year or probably more than that. Some important secondary endpoint, again, but these are the usuals that we look at in those kind of switch studies, where the proportion of people with virus load more than 50 copies per ml at week 48 and the CD4 change as well as the safety at week 48. Let's review their baseline characteristics. So their baseline characteristics are they're younger than people that were in Artistry 1, right? The median age was around 50 years old. And the females, white, Black, Asian, and Hispanics were all well represented. They had very good CD4 count, but they still had a good amount of comorbidities. Dyslipidemia was present in more than 40%, hypertension in close to 35%. And the people with at least 2 or more comorbidities were around 30% in each arm. Now the results, which you peeked at earlier, but you probably could guess that at the primary endpoint at week 48, it met non-inferiority. There were 5 people in the Biclen and 2 in the BF-TAF that had a virus load more than 50 copies per ml at week 48. Remember, this was a 2-to-1 randomization, so it really met non-inferiority. And you could see the confidence interval in the with the non-inferiority margin in the confidence interval plot on the right-hand side. And the people who met criteria for resistance that they were able to do resistance testing for, there were 4 people, 2 in each arm, and one of them from the Biclen arm at week 36 developed R263K, which is an integrase substitution, and there was no resistance to lenacapavir in this person. And this person had a prior exposure to raltegravir and dolutegravir in the past. As far as the other secondary endpoint that we were talking about, the virus load less than 50 copies per ml, you could see again 93% had in the BICLEN, 93.5% had virus load less than 50 copies per ml, and 90.6% in the BF-TAF. Non-inferiority was met. The CD4 cell count, weight, and BMI remained stable in both arms throughout the trial. Now, the safety was the other secondary endpoint, and you could see in the slide that there was no serious treatment-related adverse events reported, same as we saw in Artistry 1. There was only one grade 3 treatment-related rhabdomyolysis in BICLEN. So again, very rare events, and the most common events that were seen in at least 5% or more of people in the BICLEN arm were diarrhea, nasopharyngitis, upper respiratory tract infection, headache, and nausea, which again were similar in both arms. And these are people who were already on BF-TAF, right? So for at least 6 months and tolerating it well. You could see that there was no major events, no new side effect was seen. I think what you want to look at also, the treatment discontinuation was related to drugs was 1.6%. So again, talking to the safety and tolerability of those drugs. So in conclusion, the Artistry 2 really was showed that switching to BICLEN was non-inferior than continuing BF-TAF in maintaining virological suppression at week 48. BICLEN was well tolerated with no serious treatment-related adverse events reported. Discontinuations due to adverse events were infrequent. The CD4 cell count, weight, and BMI remained stable in both arms throughout the trial. And treatment-emergent resistance developed in one participant. So now that you've seen both Artistry 1 and 2, I think it's important to talk about switching. The DHHS, according to our guidelines, you really need to pay attention when you're going to switch patients by reviewing their antiretroviral therapy history to see if they had virological failures, and to review all their previous resistance testing, because resistance does not go away once it happens. You want to review their history for also safety, for drug intolerance in the past, and so not to use the same ones. And the really important one is drug-drug interaction in our patients that are, again, getting older and are on multiple other regimens. Important to look at comorbidities, mainly it's hepatitis B co-infection. And when it comes to resistance testing, we really like the genotypic testing much better than the archived DNA, than the proviral DNA. The proviral DNA is currently not really recommended to make decisions on, even though sometimes we use it in some difficult cases. What is really important, though, anytime you switch a patient to a new regimen, it's so important to keep a close eye on them especially in the first 3 months. So I usually try to see the patients within the first month, try to do blood work early on as well to make sure that they're tolerating the drugs well and that they're not failing the regimen. That's so important. Taking a look at what to come in this year and few years down the road, really, phase 2 and 3 drugs. We have doravirine islatravir coming up. Then that's another potential daily regimen for again was studied at the switch with the BF-TAF. We have the weekly oral regimen of islatravir, lenacapavir, again studied as well against BF-TAF. We have islatravir with uronivirine as also a weekly regimen, oral. We have the long-acting regimens, injectables and oral, lenacapavir once a year as a PrEP or others. We have new capsid inhibitors We have more INSTI coming and INSTI capsid inhibitor combinations. We have the BNABs. So a lot of interesting drugs with either new mechanism of action or an improvement on what we currently have. And again, going with more long-acting to try to include everybody. I mean, the whole goal here is to get everybody with HIV on whatever works for them that is safe and keep them undetectable so that they could stay in treatment is going to be so important for the future in order to end the epidemic. I think with this, I'm going to turn it back to you, Chloe, right?
So one of the questions Jihad was actually directed at you around the Artistry 2 study is, why was TAF resistance an exclusion criterion? If patients were already on BF-TAF and they were suppressed, why would TAF resistance matter? So that's the question that someone has asked you.
Yeah, I think it's a good point. I don't know. I don't know that we can tell how long, if you do have K65R and you happen to be suppressed on BF-TAF, it's still a relatively maybe weak regimen that could potentially fail. So why take that chance, right? I think trying to keep the study as pure as possible, I think it would be better to not include K65R. But you could see that they didn't include M184V, though, for FTC, because BF-TAF is approved to be given in people who are virologically suppressed with M184V. But it is not approved, it's not FDA approved to give it for people with K65R. That, to me, the main reason why that was entered. What do you think, Chloe?
Yeah, no, I totally agree with you. And I think also, if you want to study a drug, you have to study it in its optimal form with the person who's fully sensitive to the drug. So I think that makes perfect sense. Yeah,
and then you ask, they're very critical about what's FDA approved or not. So if you're not FDA approved for it, you really shouldn't include them in the trial.
Exactly, because obviously you're not comparing like with like. And then there's another question around why is the dose of BIC 75 milligrams in BIC-LEN and 50 milligrams in BF-TAF? And I guess, I'm happy to say, I think it's just, I think they're trying to make sure that they have an optimal drug level for a 2-drug regimen in this particularly, they knew that they were making a drug that would, was going to be, anybody can take BIC-LEN. Obviously, it's not only people on complex regimens, but because people on complex regimens can benefit from this regimen, it's an optimal exposure. So that's the reasons. Yeah.
My understanding too, Chloe, is that the way it's formulated, the bioavailability of the 75 milligram is really the same as the bioavailability that's in the BF-TAF.
Exactly.
We get the same
level. The same amount of dose, and it's not due to a drug interaction or a boosting effect of TAF or LEN. It's a bio. Yeah, exactly. So then there's a question. Someone's asked is BIC-LEN available now? No, it isn't. It's been, I think the filing to regulatory bodies has been made, and I think hopefully we'll hear soon, but it's not available now.
Thank you, Drs. Orkin and Slim, and many thanks to you, our listeners, for joining us. To view the full program and download the accompanying slides, please click the link in the show notes. To get access to all of our new podcasts, subscribe to the DSERA Clinical Education podcast on Apple Podcasts, Google Podcasts, or Spotify. Thank you and have a great day.